is six times more common than in typically developing children. We recently published a joint study between our unit and the units in Sydney, where we looked at how many kids had gone through our centre and their centre and had sleep studies over a 3.5-year period. You have to excuse my dog. And we looked at 152 children who had sleep studies. And in fact, from those studies, only 9% had never had a diagnosis with OSA. So that just shows you how many. Now, obviously, we're seeing the children who come to us and are referred with symptoms, but it is a huge population. And one of the things that I think is really important for us who are working in this field to teach others is that in Down syndrome, OSA often reoccurs and persists throughout childhood, despite treatment, which is what makes it so challenging. And I think the other thing that you're going to hear me talk a lot about through my bit of this talk is the non-respiratory or behavioural, as people like to call them, which I actually don't like to call them, sleep problems. The things like bedtime resistance, sleep anxiety, night wakings, these are all extremely common in this group of children as well. And what we've recently shown in some of our work, and I'll share with you today, is that there are potentially many children in the community who are not being treated for these problems in particular. And I think this is something that is really, I feel very passionate about being able to actually raise awareness about for children with Down syndrome. So moving on, what is the impact of having sleep problems in a child with Down syndrome? Well, we sort of know the answer to this. We know that poor sleep has negative effects for typically developing children. That's now well published. And we know that children with Down syndrome are likely to be more vulnerable to their sleep disruption because of their existing developmental disability. But we don't know how much it impacts what you actually see in this group of children, because we know there's a quite varied spectrum of disability in this group. We've got some small studies that have shown that children with Down syndrome who have sleep problems like OSA have slower language development, worse cognitive outcomes, and poorer accomplishments of daily life functions. So the theory is that if we improve sleep, we could actually potentially help to improve outcomes in children. And this is really where my research started, because there are actually no studies that have evaluated what the impact of treating sleep problems is on the outcomes we see in this group of children. So here is an overview of our body of research that we've been doing. It's probably a bit overwhelming when you look at it like this. Basically, I just wanted to kind of show you what I'll be talking about and some of the things that we've been doing. So we kind of started with this question here: how common are sleep problems in Australian children with Down syndrome? And we have recently published this work, and we were kind enough to have the support of Down Syndrome Queensland and Down Syndrome Australia to undertake this survey through an online method. And what we've done is, from that, we've actually also recruited a group from the community that have that are taking part in a longitudinal follow-up study. So we're following children with Down syndrome over 24 months. We've got two groups, and we're trying to answer this question: does treatment of sleep problems in children with Down syndrome improve their overall outcomes? So we have one group that we've been following from the sleep clinic, who are children who've been referred to me or colleagues within my department. We've been following what interventions they've been having for their sleep. So for example, if they've had surgery for taking their tonsils and adenoids out, if they've had CPAP commenced, and then we've got another group in whom the parents don't report that there are active sleep problems. They aren't under a sleep clinic, and they're just out in the community. And we're following both these groups up, and we're doing 24-month follow-up. And the reason this one's shaded is because this is actually the one I'm not going to talk about in more detail today, because the results are still being finalised for the 24-month follow-up, and I'd really like to share that when we have the full results available. But I've got plenty of other things to talk to you about, so don't worry. The other one, which I think is a really exciting one, is this one up here. Is home monitoring possible to diagnose sleep breathing problems in children with Down syndrome? And those of you that have come through and had sleep studies will know how challenging that can sometimes be. And so I've been really privileged to work with Professor Colin Sullivan, who's actually the creator of CPAP. And he has developed this new maps that I'm going to talk about a little bit today, and tell you about the study that we're running at the moment through the Children's Hospital. And we've got about about 30 participants at present, which is fantastic for our first year. And then finally, I'm going to leave by talking and introducing this really important one, which is what is the impact on parents, carers, and siblings of looking after a child with Down syndrome who has sleep problems. And I will be setting the scene for this one and then handing over to Emma, who, as Daryl rightly said, is much more eloquent at sharing the findings from this study than I am. So moving forward then, so question one was, how common are sleep problems in Australian children with Down syndrome? And what we set out to do was really just look at that exact question. How common is it? How prevalent are these problems? And we looked at this community sample of children with Down syndrome and also a group coming to our sleep clinic at the Children's Hospital, so those that have been referred. And obviously you'd expect that in the referred group, we're going to see lots of problems. So what we did is we did a survey and we asked both groups of children to fill out this questionnaire called the Child Sleep Habits Questionnaire. And we used an abbreviated version so that it wasn't lots and lots of work. On this questionnaire, a score of above 41 suggests a significant sleep problem. So just bear that in mind as we go through some of the results. Additionally, in the community group, we asked the question if the parent had ever had concerns about sleep in their child, and if their child had ever attended a sleep clinic. And in the referred group, we looked at the reason why they had been referred to the clinic. So looking at the results, now this is a bit of a busy slide, but just to show you, we had 76 participants from the community, not all in Queensland, but a great number for this kind of survey. We had 42 that were from the group that have been coming to our clinic. They were slightly different in their age ranges, but it actually wasn't significantly different when we looked at it statistically. And you can see the range here of ages in there. We've got a 50-50 split of males and females, which is quite nice. But what you can see straight away looking at these numbers is that both these groups are scoring high. So 41 was that cutoff. And look at these scores, 57 as a mean for that group of children in the community, 52 for that referred group. So the interesting thing here is we actually had a higher score in the group in the community than we did in the group that are coming to the sleep clinic and are the ones that have been referred with a sleep problem. And this is just showing that same finding in a graphical way so that you can see that they're both scoring. And if I was to put a cutoff line, it would be about here, just here. So this is the mean score that they both had. So what we've basically shown is what's not a surprise to you both, which is that sleep problems are really common in both groups of children. And what we've also highlighted is that there's possibly actually many children in the community that are not being treated for these problems. And I think I can understand the answer to that, answer to why that might be to a certain extent, but I'll be really interested to know what you guys all think as well. We found that 74% of parents in the community group actually did have concerns about their child having a sleep disorder. None of them, as I mentioned, were actively under a sleep clinic, but less than half had actually been previously seen. So there's obviously a barrier to being referred to the clinic somewhere. When we looked at the clinic sample, the ones that were coming to the sleep clinic, we had 92% of them that were referred due to snoring. Now, this score that I've been talking about, this Child Sleep Habits Questionnaire score, does ask questions about snoring, but it's really only about 2 questions within the whole questionnaire. The rest of it actually focuses more on those non-respiratory, more, if you like, behavioural things that go on for sleep. So, in fact, having a high score for that, that questionnaire actually represents that there's probably 2 sleep problems going on in that group that were referred to the clinic. And I wonder whether the reason they're being referred is because of the snoring. And that's why we pick up that they've got another sleep problem going on as well. Whereas the group that are still in the community, potentially that's because the snoring is not as much of a big issue. I don't know, that's my thought. Nevertheless, what it really highlights is that we need to try and improve the awareness of sleep problems in children with Down syndrome. And that's really something that I will be trying to take forward over the next year or so and work with Daryl and the team to try and improve. I thought I'd put this in. This is a quote from one of the interviews, and Emma's going to obviously talk to it more, but I put this in just to highlight exactly how this needs to be highlighted and why it needs to be highlighted. We went to the pediatrician constantly. I remember crying because I did have a mental breakdown. He's not sleeping. He wouldn't believe us and would just say we need to treat him with dog commands. And to me, that is just unacceptable. And it also highlights to me that people, medical professionals in the community are not aware that this is a significant problem for this group of children. Okay, so moving on. The next question, remembering that I've missed out question 2 on purpose, is to look at if there is an alternative to a sleep study to diagnose sleep breathing problems in children with Down syndrome. And as I said, this is one I'm really excited about. Before I talk about it, I just thought I would tell you a little bit more about sleep breathing problems, or sleep disordered breathing as we refer to it, in children with Down syndrome. And predominantly when we're talking about this, we're talking about OSA, or obstruction. Now, children with Down syndrome are more at risk, as I've mentioned, that it's about 6 times more common in this group of children. And the reason for this is due to a number of reasons, but largely due to some of the features that will be very familiar to you all. Having the flatter midface, the larger tongue, a bit of a shorter neck. We know that their upper airway is in fact quite crowded. And if you go to see ENT specialists, they might talk about the nasopharynx, which really just means the upper airway, a shortened palate, and the low muscle tone. And all of these things mean that when children go to sleep at night, their airway will relax and flop even more than normal, and their upper airway will be more crowded. And that's why they have this, what we call obstruction, where it's difficult for them to get the air in and out while they're trying to sleep. This is made worse by other conditions. So having obesity, having some cardiac disease, having hypothyroidism will all be things that we would ask and would all potentially contribute, not always, but could contribute. And the way in which we diagnose this, so the way in which we look for this is with a sleep study in the lab, which a fancy word for a sleep study in the lab is called polysomnography, or PSG. And as many of you will be aware, this involves many leads for monitoring, and it can be really distressing for the children. It's very labor intensive, and it does need the specialist environment. And interpretation of the findings can also be quite difficult for us for many reasons, partly because of the information we're gathering and the limitations of that information, but also partly because a lot of the ways in which we interpret this data is extrapolated from adults. And as we all know, adults and children are very different, and children are not just small adults. So here is what I look at. So most of you will think this is just squiggly lines, but what I actually look at is this. This is called a sleep study, and this is what we get when we put all of those leads on. And I'm not going to obviously spend ages on this, but what I just wanted to show you is what I look at so that you can see why I can be fairly confident about what I say when I tell you that your child may have significant obstruction. This is an overview of the whole night, and we collect information about oxygen levels, heart rate, carbon dioxide, respiratory rate, and we can see when there's big dips occurring through the whole night. Here we get a screen that tells us about a certain period of the night. So this is just a couple of minutes through the night, and we're looking at it during a period of dream or REM sleep, which is where you drop your tone more. And here what you can see is that this child's breathing is quite abnormal. So the airflow has dropped off, the air is not getting in. That's what this channel is showing here. And as a result of that, the child, despite trying to keep breathing, which is what you can see here in the bands that are around the chest and the abdomen, the child cannot get the air in and the oxygen saturations drop. And we see that this is happening repeatedly, and this is just a 2-minute window. So you can see how many times that's happening through the night. So that's what I look at when I look at sleep studies, and that's how I make a diagnosis for you. However, I also wanted to share with you some of the stuff that comes from our nurses when they do their technical report. So what the nurses tell us is things like this, and this is taken from a child with Down syndrome, distress during setup. We weren't able to get EEG leads on, no thermistor, no nasal prongs, no CO2 monitoring. I was unsuccessful with trying to recite the thermistor through the night. I wasn't able to score it properly. The sleep was very fragmented because the child was waking lots through the night. There were lots of technical interventions to position the nasal prongs and the CO2 monitoring. The cables and the bands were replaced separately twice. And then the child wakes up in the morning, and this is really not what we want. The child was reluctant to be touched by nursing staff, but happy with mother. So this is just to highlight that we are aware that this is difficult, and actually we don't want this situation. We don't want to be the people that the children don't want to touch them in the morning. So we do need alternatives, and that's where this body of work came from. And this is the man himself. This is Professor Colin Sullivan. This is the guy behind this mastermind, and he as I mentioned, he created CPAP. He was the very first person to try CPAP with his own setup, not the fancy ones that you use nowadays. And he has been acknowledged worldwide for his contribution to sleep medicine. He has developed this mat, and many of you will perhaps have seen this. This is what it looks like. It's very simple. And what the mat does is it sits on top of the child's mattress under the bed sheet. But it's actually quite sophisticated inside. So it looks like just a little mat, but it's got 4 sensors inside it, which are situated around this area, that detect movement and breath sounds. And it's also got 2 room microphones at the top so that we can tell if there's noise within the room that might be interfering. They've shown that this mat can be accurately and safely used in typically developing children to assess and diagnose for sleep disordered breathing and OSA. It does not involve any leads, and it can be used at home, and it has been used at home in typically developing children. And so this was where I approached Professor Sullivan, and I said, I really think this is something that we need to show works in children with Down syndrome, because this is a group that's crying out for something that is not requiring lots of leads to be attached to them. So that's what we've done. And so we've set up this study, and we're trying to see if this mat, the Sonomat, can be used in children with Down syndrome to evaluate for sleep disordered breathing, both at home and in the lab. And we want to compare it to the diagnostics gold standard, which is our PSG or sleep study. And we want to also know what families think of it. So that's really what we're trying to do. We're looking at children between 2 to 16 years, and the reason it's set at 2 is because that's the age at which the mat can be used for safety perspective. And it's for children who come to us and need a sleep study, so that we're doing a sleep study anyway, and therefore we have a comparison. The Sonomat we're using at the same time as the sleep study so that we've got a direct comparison on the same night. And then we're also asking families if they're willing to take it home and do 3 to 5 nights of monitoring at home and keep a little sleep diary for us at that time. And then we ask families to fill out a questionnaire about their experience. And we also ask them to tell us about their experience of the sleep study as well, which will be very interesting to look at. And then what we're hoping to do is compare the results from both the Sonomat and the sleep study, and also look at what the additional information is we get from home, because we're very aware that children sleep differently in their own environment. And one night in the lab, sometimes we don't pick up the things that we really need to pick up. And we are obviously really interested in what families think of this. So we've had some preliminary results looked at, and I analysed these very quickly for a conference presentation at a national meeting. And it looks really promising. So we've had a couple of failed recordings, which was really because people forgot to press the button to turn it on. And actually that was more of a problem in our nursing staff in the lab than it was at home. I'll just point that out. From parents, generally, it was felt to be a really good option instead of a sleep study. And parents rated it as an excellent, good, or very good option. It was safe and has been well tolerated at home in children with Down syndrome. And looking at the actual results so far, it looks to be comparable in terms of the results it's giving us to diagnose sleep disordered breathing. That's really exciting. We're also getting some really useful additional information about snoring and other noises in this group of children that we don't necessarily get from our sleep studies. So we may actually find that we're getting some more information that we don't get from the sleep study. So we're now up to 30 participants, and we're hoping to reach a target of 100. And given that we only started recruiting in about March of April of this year, I'm pretty hopeful that we're going to reach that target next year. So watch this space on that one. So finally, to talk about the one that I have become really passionate about, which is how does caring for a child with Down syndrome and sleep problems affect families? And I'm going to really just introduce what we've been doing here. So what we wanted to do was try and understand sleep difficulties in children with Down syndrome across childhood, and try and identify, first of all, are there any patterns that exist relating to the age and stage of development? And we want to know that from you, not from what medical textbooks tell us, but from parents who are actually going through it. We wanted to evaluate how sleep difficulties impacted on parents and also on siblings. And we wanted to evaluate whether it was impacting health and well-being of the family unit as a whole. And we also wanted to know whether there was a way of telling if treatments were actually improving outcomes for parents and families. So what we've done is a mixed study. We've done part of it, which is called qualitative, looking at interviews. So Emma's going to talk about this, but we've done some structured interviews with specific themes. We've also got families to fill out a pictorial of their child's sleep from birth, and I'm going to show you that in a second. And then we've asked families to fill out 2 questionnaires, which are actually about parents. So asking about your scales for depression, anxiety, and stress, and also about quality of life. And we aimed for roughly about 20 families from the sleep clinic. And our next step is to do 20 families from the community. And that's the bit we haven't done as yet. We're just starting that bit. And we've also tried to interview some siblings, which was actually a brilliant idea from Emma to include this in our study, because I think it's going to be really interesting. So here's the timeline. So this is what we've asked families to fill in. So depending on the age of your child, you get one of these timelines. I'm here showing the one for children up to 4, but if your child is 14, we would give you one that goes up to 14. And really what we're asking you to do is we've asked families to just grade where they think their child's sleep was. They were given a score, and asked to grade their child's sleep and write any comments about what they thought was going on, if they could remember about their child's sleep at that time. And we recognize that that's difficult if your child's 12, 13, but it was just part of an interesting little side thing that we thought we'd do. So to share some general observations from this, here's we've got data from 19 families, and they were asked to rate between 0 and 5, with 5 meaning your child sleeps amazing and 0 meaning your child sleeps awful. And you can see that families actually didn't rate children particularly high, which is, I think, the first thing to show you. But you can see that it does sort of seem to sort of improve a little bit from around 5 potentially, but you still only really get to a score of 3. So that's interesting. Here are some comments from families. So always, and the interesting thing about these comments is that from birth to 5, the focus is very much on breathing. Always has had bad sleep from birth due to OSA, woke often with troubled breathing, very restless, would stop breathing, wakes often and tosses and turns, snoring, stride or sits up. When you get to 5 years onwards, this is what I find really interesting. Needs parent to fall asleep, would look for parent in the middle of the night, late to bed, attempted different bedtime hours, waking frequently to find parent, sleeps in a strange position, mattress on the floor for him to sleep if he comes in, wants to have his feet touching mum when he's asleep. And you can see there that this is where we're seeing a different pattern to what you would see in typically developing children. And you can see that it's the non-respiratory or more behavioral things that start to take over. And I think that's a really important finding from this study that we will be looking to address. What about treatment? Well, this is interesting. So this is showing us a little bit about individual patients. And patient A here had adenotonsillectomy performed at this point, and you can see that sleep does improve after the adenotonsillectomy, plateaus out, and then we started some treatments for more things to do more with routine, and then we get some improvement, but it takes a little while to kick in. So that was quite a nice one to see. This one, on the other hand, was interesting. This child started off not too bad, got a bit worse, had tonsils and adenoids done, then actually doesn't get better for a while. And you kind of go, I'm not sure that child's had a brilliant result. And then something happens, and maybe it's just time and age and things improve. So maybe this suggests that this child actually had more of the non-respiratory things that were causing the problems with sleep than the tonsils and adenoids really kicking in and making a difference. But it also highlights that we don't always see improvement after this kind of surgery. So that's a really important thing as well. So lastly, my last sort of little bit is just to talk about the quality of life and mental health. And really, we had data from 23 parents who filled out these 2 questionnaires that I've mentioned. The DAS scale, this is the mean and median scores for the groups. You can see here the depression score was 8, that classes as moderate. 5.36 for anxiety, which is also moderate, and stress levels well up there in the moderate to severe range. So interesting findings from a small group of families at present. Looking at quality of life, this is assessed in 4 different domains. And I've put the norms here. So this is from the population norms when they've done the reference values for these questionnaires. And you can see that higher scores mean better quality of life. And you can see here that our parents are all sitting as a mean group well below these general norms. So we've got some work here to do to try and improve this for our families. So lastly, what have we learned from interviews with families? And that's where I'm going to stop, and I'm going to hand over to Emma. But before I do that, I just do have to take a minute to say thank you to so many people who have made this research possible, and who have supported me through everything. And first and foremost, that's the families of the children with Down syndrome who've participated and continue to participate in my numerous studies. And they come to my clinics, and they come to other people's clinics, and we say, would you like to be part of this? And I don't think we very rarely get someone that says, not right now. And it's usually not right now rather than no. Thank you to Daryl and the team at Down Syndrome Queensland and also Down Syndrome Australia, my supervisors from my PhD, our department, and also my research group, who I could not do this without. Statistical support from UQ, and my funding, which has been instrumental in giving me the time to really put this work together. And that's where I'm going to end. And in ending, I will also stop sharing and take 2 minutes while Emma shares her slides to introduce her. Daryl's already done a fantastic introduction for Emma, but I will just add that Emma recently was awarded her PhD. So she is now Dr. Emma Cook. Emma joined our team by doing an industry placement during her PhD, and works with the team at the Institute of Social Sciences Research at UQ. And she has brought a wonderful new perspective to our research. And I think you're going to see that when you see what she's been doing in the background here. So Emma's going to present, and then we will hopefully have some time for questions. So thanks, Emma. I'll hand over to you.
Thank you so much, Jas, and thanks, Daryl. Can you see my slides okay? Excellent. So thank you so much, everyone. Today, I'm going to be presenting my perspective as a sociologist on these families' experiences. And I think it's important to just briefly introduce what is sociology. So generally, sociology can mean viewing personal problems as social issues. That's one way to understand sociology. So, and it's certainly why I fell in love with sociology, because often our struggles in life can feel really personal and like they just belong to us. But when we bring a sociological point of view, we begin to see how we might have things in common with other people that share some of our characteristics. And we begin to think about how, our problems are shaped by different social forces, in particular, different attitudes. So in the case of families of children with Down syndrome, different prejudice attitudes towards people with Down syndrome, other social forces like gender norms of what do we expect from mothers in Australian society, class, how much money and resources do you have, and also social policies that shape things like funding for the NDIS and Centrelink. So these are some of the social forces that I'm trying to highlight and critique as I share some of the stories today. So I'm going to be presenting 3 stories of mothers that I've interviewed. And I hope that even though they're just 3 women, that you see that they kind of in some ways represent a lot of women and a lot of people's experiences and a lot of parents' experiences as well. And I hope you appreciate that I've used some humour to sort of critique some of those power structures and those social forces that do shape these mothers' lives. So I will move on with the presentation. I'd like to acknowledge that I'm on Turrbal Yagara country and pay respect to elders past, present and emerging. Okay, so this is the first mother's story, and these are all de-identified, so I'll be using pseudonyms. Genevieve. The diagnosis was a very rushed but nice conversation. She thinks everyone might have assumed that someone else had offered support, but no one had. Her baby is 5 weeks old and really unwell. This rude nurse asks her if she knew that he had Down syndrome and tells her he will be a burden all her life, and if she had known, she would have chosen not to have had him. He is 3 now. Genevieve gets up a lot just to put him back in his cot. A lot, like probably 40 times. She is not exaggerating. One time, Genevieve woke up to the sound of the shower. He turned on the hot water, Thankfully, he didn't get in because he has no concept of hot and cold. He climbed into the bathroom sink and he was trying to eat hand wash. That's the one occasion Genevieve was incredibly glad that he has a medical condition where he can't swallow. He didn't have surgery for his obstructive apnea until maybe 8 months ago. She had been saying there was an issue for so long. She remembers one of the doctors told her, "Oh, that's normal for Down syndrome." It puts a blanket over the situation. It's like saying, "Oh, you have a heart defect. Oh, this is a common heart defect, so we'll just leave it." A lot of the reason she kept pushing is because she would also go on her mum's group, Parents of Children with Down Syndrome, and be like, "Hey, is this normal?" She has learned over time to be more assertive. Genevieve applied to the NDIS for a genie bed, which is something that could keep him contained and also elevates, so it's better for his lungs. Sometimes he wakes up and because of his lung disease state, his lungs are full of mucus, so then he can't breathe. Genies grant 3 wishes, but Genevieve's life is not magical, and instead the NDIS has granted her 3 denials to her applications for a genie bed. Genevieve has taken to her application to the Administrative Appeals Tribunal. If they deny it again because they said it was a restrictive practice, she'll have to go to the local MP because she honestly doesn't know what else to do. Genevieve rang the NDIS to ask why they denied the bed and discovered that her son is not a son, but rather an item. And no, they do not know who she is talking about. And no, they do not know any details about him at all. But they do know that item is denied. Thank you very much. Never mind that Genevieve and her son will sleep better with a genie bed. That's a Genevieve problem, not an NDIS issue. What do you think that place is? Some sort of national disability insurance scheme? Nothing is cheap ever, not even breathing. Genevieve feels that she cuts a lot of corners with everything. She does a lot of ready meals. Genevieve always feels like she's not doing enough with her kids. They'll ask her, "Oh, come and jump on the trampoline," and she does not have the energy for that. Sometimes she zones out mid-conversation. Genevieve had wanted to go to uni, back to uni. She thought after she had her son, she'd possibly be able to do that and just study while she parented as well. But there's just no capacity for Genevieve to do that. She's just so tired she can't remember anything. She's also incredibly busy. There's a lot of medical stuff, taking her son to and from a lot of therapies. She's just so tired she can't remember anything. She actually has the uni books. She reads them for fun, but she just doesn't want to enroll and get terrible grades. She's on Centrelink at the moment. She's on the carers and family tax benefit, so it's a lower income. She really hoped she could study, and when her son was in school, she could do work shifts around that. She's not really sure what she's going to do. Genevieve wants to be a very engaged parent. Unlike her ex-partner, he didn't really want to be engaged at all, but she feels that she is just good enough. Whitney. Whitney wanted to enjoy Brie when she was born, but instead a pediatrician took her enjoyment and replaced it with a puzzle. How does Brie look? Like her other children? Yes, she just looked very similar to her other girls. Why do you say that? A couple of the nurses think she's Down syndrome. That was it. Never said anything else. Whitney worried over this puzzle for the 2 weeks she was in hospital, but she was unable to solve it. On the last day, they took a blood sample to test for Down syndrome. They were sent home and told to come back in a week, and the midwife came out and said, "No, I'm doing the test now." And the pediatrician went off at Whitney. "Why didn't she come in?" And Whitney called her doctor, who reprimanded the hospital and sent Whitney to a new hospital and specialist. Simple and streamlined care pathways. Brie was sleeping quite a lot. She was tiny. Whitney was breastfeeding her, but she just wasn't putting weight on. They didn't find out until a year and a half later the reason why. Spoiler alert, it's the mum's fault is what they say, and we always trust them. Some doctors have a penchant for diagnosing mothers with being women. Prevalence, common. Symptoms unreliable hypochondriacs. Prognosis incurable. Back in hospital 3 times, really sick, pneumonia, severe bugs, pediatrician. Oh, next time we'll investigate, next time we'll investigate. Referral to a health clinic to see a dietitian. Whitney didn't realize it at the time, but they thought she wasn't feeding her baby. Is it just me or are the lights flickering? Whitney had 3 companions in her bedroom: her husband, her baby, and Fear. She always slept lightly with Fear, who muffled her ears as she strained to hear her baby's breathing or lack thereof from the cradle and later cot beside her bed. 4th time, Floppy, not responding, wouldn't wake up. In the ambulance, there is a man and he insists a different hospital. Intensive care, surgery to take out tonsils and adenoids. Her airway was just like a pin drop. Bree was using up all of her energy to breathe. That's why she wasn't putting any weight on. Airways opened, a light switched on, and Bree started developing. Whitney is classed as Bree's carer, although she hasn't applied through Centrelink to get the carer's payment. She's just doing the carer's allowance. The problem was Whitney was too busy being Bree's carer to prove it to Centrelink. Answer this riddle. If a job application falls in a forest and Centrelink is not around to hear about it, does it make a sound? Complete this quest, retrieve the diagnosis letter, scavenge for the correct Centrelink forms, and ask your doctor to fill them out. Whitney needs to take her daughter to appointments. If she was to work, who would do that? Sometimes it's frustrating. How are they going to make ends meet? There's times when Whitney gets itchy fingers. She wants to go back and do her creative work again. She's been approached with work opportunities and gets excited, but it just doesn't feel right. Now is her time to be there for Bree, trying to keep that positivity and help her experience as much of a normal life as she can. What's normal though? Adeline. The research and the to-dos are how Adeline copes. On guilt. Adeline wasn't diagnosed with anything, but she probably landed in depression and stayed there for 10 months. Her child caused this vacation, and shame wrapped its arms around her so snugly that she couldn't even wiggle an arm free to lift her thumb out and hitch a ride out of town. Adeline handpicked the chromosome, who she describes as Maisie's 3rd parent, because it affects her life completely. Except Adeline didn't do that, but guilt insists otherwise. Adeline connected with mothers of older children with Down syndrome. These mothers brushed the gritty guilt out of her eyes so that she could see that their children and her child are perfect the way that they are. On Maisie's fatigue. Some doctors were door-to-door salespeople. Can I interest you in this fine collection of "that's just because she has Down syndrome" excuses, featuring the greatest hits? She's tired, but that's okay because she has Down syndrome, and she's a bit low in B12, iron, vitamin D, but that's okay because she has Down syndrome. Adeline slammed the door shut on those offers every single time. She is a subscriber to "Could we improve this somehow?" and "I want her to be the best that she can be." On COVID. COVID is a bad thing, but it has been good for Adeline's family. COVID left her husband's work intact, but vanished his travel briefcase. COVID picked up the screaming kids that Adeline was dragging across town to appointments and calmly placed them at home with afternoon tea, homework, and Zoom therapies. Fortnightly speech therapy became weekly. COVID put the specialists, pediatrician, gastroenterologist, endocrinologist, pediatric hematologist on telehealth. COVID slotted the husband next to Adeline in the appointments because they were on Zoom. They receive more cohesive answers now because he picks up on things that Adeline doesn't. Really brilliant. On work, there's an impact on Adeline's life that we haven't talked about. She stayed at home for 11 years. She thinks perhaps if Maisie had been born without Down syndrome, she might have gone back to work, but she didn't. On quality of life. Adeline doesn't think that her quality of life has changed. Adeline applies a class lens to analyse her experiences, although she doesn't use those words, she uses these. We're lucky enough that my husband's job, we haven't had to give anything up in order to give her what she needs, what we deem she needs. We've spent a significant amount of money, so I can understand if you weren't as privileged as we are, how your quality of life could be affected, but we are very privileged. So thank you for listening to those 3 stories. I want to leave with some final thoughts. So reflecting on these stories and your own experiences, I'm really interested in this question of, how does parents internalize judgment impact their lives and their child's treatment and outcomes? I'm also really interested in, how do judgments from medical professionals impact parents' lives and children's treatment and outcomes? And I also would love to hear what questions this raises for you and, why you consider different thoughts from this presentation important. And please feel free to email me. And I also need to acknowledge that as a researcher, I'm funded through the Centre of Excellence for the Digital Child. Thank you so much to all the participants. Thank you, Jas, for involving me in your research. And thank you so much, Daryl, for hosting us tonight. Thank you.
No problem. Thank you very much, Emma, and thank you, Jas. Look, we do have time for some questions. Feel free to put them in the chat, please, and then we'll put them to either Dr. Jas or Emma. And in particular, if you have any thoughts on those questions Emma just posed, that'd be great to hear them as well. We've got one question there already for yourself, Dr. Jas. Are there any standard recommendations for when children with Down syndrome should have a sleep study, even when there are no obvious symptoms noted by parents?
Yeah, thank you for that question. So that's a really, really good question. So there's actually only one recommendation out there, and that's from the US guidelines, which suggests that if a child reaches the age of 4, and hasn't had symptoms, then they should have a sleep study. That's the recommendation. If you have symptoms before that, then obviously you should have a study before that. I'll just highlight 2 things that there's an issue with that, and that's actually something that we are looking at, trying to put some guidance around. One thing I'll say about that is that it would be great if we could do sleep studies on every child by the time they got to 4. The reality is that the sleep resources we have are strained already, and we struggle, and we do prioritise the children with Down syndrome as much as we can. And those of you who've been to us know that we try and do that because we're aware of how much of a problem it can be. But across Australia, it's not the same for every lab, and we are quite fortunate in that we do have the ability to, we have the biggest lab in Australia, but it is hard. And as I mentioned, the services are very strained and are very specialised. So you do need very specialised nurses, equipment, and the respiratory sleep specialists who can interpret the results. So that's one thing. I think the other thing to just point out is that when we did our study within Australia, we actually found that a lot of children were having symptoms and were actually having quite severe obstruction in infancy. So although the recommendations are saying that by the time you get to 4, you should have a study, we actually showed that there was a big group of children who were younger. Now, yes, they were children who'd ended up in our service, so they're probably children who've been referred. But I think it's really important to point out that these symptoms, they are, some of those kids who don't have symptoms have equally a severe disease when we actually study them. So I think if you have any doubt, it's worth asking for referral.
Excellent. And that's something you just ask your GP for and they'll refer to it?
Yeah, that's right. That's right. So your GP or your paediatrician can send a referral through to us, and you will then be triaged through our service and receive an appointment first, and then you would go on to have a study if it was felt to be required. And in most cases, that does occur for this group of children.
Excellent. Thank you for that. Next question we've got is, do you find children with heart problems have more complex sleep issues? Is there a connection there?
Mm-hmm. That's a really good question, and something I'm really interested in, and actually just looking at with some of our data. My answer to that question is that yes, I think they do have more complex sleep issues. I think that particularly, again, thinking about the infants, we see a lot more of those infants that have mixed sleep disordered breathing, and by that I mean that they have the obstruction, but they also have the central control side of things that I haven't gone into in a lot of detail in my presentation. But yes, I think that the heart, it's not necessarily that they have, I think the reason it's more complex is because the heart side of things makes them more vulnerable and more likely to have desaturations associated with events as well. So I think, yes, they do have much more complex disease, and a large number of those children come to our service through the cardiologists as well.
Excellent, thank you. We've got a question about the sleep mats, and good one, because I know I've got a daughter who this would apply to too. Would the sleep mats still potentially work for a child who moves all over the bed during the night, or do they need to stay in a particular spot for the sensors and everything to work properly?
Yeah, so that's exactly why I wanted to test it in this group of children, because the number one thing that every single family tells me when they come to clinic is how much their child moves through the night. So the beauty about the mat is it does have 4 sensors in it, and the 4 sensors are spaced across the mat. So in actual fact, all that happens is that you end up recording from a different channel if the child moves. So actually we think it's going to be fine, but that's actually one of the reasons why we wanted to test it in this group. And so far it looks as if we're picking up enough data in the children that we've looked at to suggest that it is going to be okay.
That's great. And I'm sure more generally it was great to hear those mats are looking like they'll be a great option for children with Down syndrome, that would avoid all those wires and tubes and everything being connected. So
yeah, I think it's
how many have you got, Jas?
So I have been very lucky to have been provided with 3, and I think I'm one of the luckiest in Australia, because they're not easy to come by. Colin keeps them under wraps at present. They're only being used in a research sense at the moment, so you can't use them for clinical reasons, because we're still doing research to ensure that they're safe and that they're accurate, and we don't want people to start using them before we have that data. But yeah, I have 3. So you can imagine that we have them going out and coming in fairly regularly. But we've been very blessed to have a good relationship with him, and he's been very generous. So, you know, really acknowledge his input.
That is fantastic. Yeah, they sound brilliant. We've got another one about tonsils and adenoids being removed. So a girl who had her tonsils and adenoids out in February, but sleep has still not improved. Does that mean that the issues are likely to be more behavioural? And if so, how can they be addressed?
Yeah, so that's a difficult one. I mean, I guess individuals are so different. It could mean that it's more non-breathing relating, but equally we know that the success rate from adenoids and tonsils is around 50% in this group of children. So if you're still concerned that you're having symptoms, then it's definitely worth coming to see us, and we can decide whether any further intervention is required or any further investigations are required. In terms of actually treatment for the non-respiratory side of things, that's actually the next bit of our studies that we're trying to set up at the moment, which is to actually look at, we have a grant that we're waiting to hear about that will hopefully be a way in which we can actually look at providing some tailored advice for those problems, specifically in children with neurodisability. So one of the things that we have at the moment is some very general advice that we use for all children. But one of the things I recognize more and more as I go through my research and my clinical experience is that children with disability, whether it be Down syndrome or others, are very different. And some of the things that are advised for typically developing children, they're just not quite right for this group of children. And what we're hoping to be able to do is a trial where we can actually see what works and what doesn't work, and then tailor it to this group of children. So watch this space. Hopefully we will be working in that space soon.
It looks like from the results you shared earlier, you wouldn't have a shortage of participants for that part of the study either, Jas.
No, I think that one will be, you know, I think I'll be calling on everyone to join that one. So
yeah. Excellent. Look, a follow-on question from that, which actually relates to the next one as well, is once you've had the tonsils and adenoids removed, and there's still sleep issues, is it worth then just doing another sleep study at that point?
Yeah, look, it really depends on the situation. In most children's most children, if you've still got symptoms with sleep afterwards, I would say what is important is to see someone who has experience in sleep problems, and that's a sleep specialist. And the reason I say that is because we have a pretty low threshold for repeating a study in a child who we know has a risk of having residual disease. But equally, it may be that through that discussion and that conversation, we can work out if there are things that we can do that are more important than focusing just on a repeat study. So I think the most important thing is that you voice your concerns, and that you make sure that people are listening to you, which Emma's obviously talked about that I know that that's sometimes a challenge, but people are listening to you when you say no, things are not better. So I think it's really important to go back to that sleep specialist at that time.
Excellent. Yeah. We've got a few people on the webinar from outside Queensland, which is awesome to see, and that's led to a few questions around: can they get the MATs in Sydney? How can they sign up for or are they allowed to sign up for your studies being outside Queensland? And I know you do have people on your studies from outside Queensland, so maybe you could talk a little bit about that, Jas.
Yeah, sure. So far, the MAT study at present is just in Brisbane, however, or in Queensland. As I mentioned, we do have a big grant that we're waiting to hear about, and that is actually a collaboration with the team in Sydney. So if that comes through, then the hope is that we will be able to recruit from both Sydney and New South Wales and Queensland, and that's what we're hoping. And we've also in talks with people in Victoria, so we are trying as best as possible to try and expand this. The stumbling point is always funding for these things, because it obviously takes a lot of manpower and a lot of coordination to make that work across the centres. So the answer to that question is, at the moment, the MATs are not available in Sydney. There are some studies going on in Sydney with the MATs, but they're not in this group of children at present. That's not running at present. Hopefully soon is the first thing to say about that. The second thing to say is that some of our studies, as Darryl rightly mentioned, have involved online survey work that is involving people from all across Australia. And it was great to get that input from others across Australia. And yes, that is something that will be open, and we will definitely be working with Down Syndrome Queensland, Down Syndrome Australia, to make sure people are aware of the studies that we're doing. And I see there was a question there about how you can sign up for next studies. Basically, your port of call will be through Darryl and the team, and through Down Syndrome Australia. We will make sure that everyone's aware of the things that we're doing and what the recruitment criteria are. Obviously, I'd love to include absolutely everyone in every study, but we do have to be able to get good results. We do need to sometimes set the criteria quite strict. So just, don't be disappointed if it doesn't fit for you at that time. But hopefully there'll be something coming that will fit for everyone at some stage.
Excellent. That's great. Look, conscious of time, we've nearly run out of time, and we've responded to most of the questions there, which has been fantastic. Dr. Emma, sorry for not calling you doctor earlier. Dr. Emma.
You didn't know, it's okay.
No, that's right. Thank you so much. Fascinating as always to hear the results of the studies that you've been doing and your work. And look, from Down Syndrome Queensland, Down Syndrome Australia, and all the Down syndrome population, thank you so much for everything you do, because you've shown with the data what an important area it is, and the impact that it has, not only on the child with Down syndrome, but on the broader families as well. And I think it's really interesting to and beneficial that you are going beyond the pure sleep studies and looking at the further impact on the families, and Dr. Emma, the work you're doing around presenting some of those stories. I think it's great to hear that, and to take those studies further. And look forward to fingers crossed you getting that funding to take it further around the behavioural side of things. Let us know if there's anything else we can do to support that. And look, Emma, your stories, I'm sure most people on this call can relate to at least parts of them. I know myself, I can relate to most of those things, having an 11-year-old with Down syndrome. And I think it's also, as I said in the intro, a really powerful way to present information, and definitely one that I've said to you in the past. You know, we're really keen to use some of that and use it to present the information more broadly, because I think it does get it does have that impact, and I know it had you know, it's had impact on people who've been listening to the webinar tonight. So look, Dr. Jas, Dr. Emma, thank you very much. Thank you to everyone who's been online listening this evening as well. And if you do have any more questions or anything, feel free to get in contact with us here at Down Syndrome Queensland. Our details are on our website, or also with Dr. Jas or Dr. Emma. So
Thanks so
you.
much, Daryl. And just for anyone who is asking about email addresses, anything you send to Emma, anything you send to Daryl will get through to me, so don't worry. Yeah. Yeah, thank you all for listening. And again, thank you to Down Syndrome Queensland for the opportunity. We really appreciate the families and everything you've done to support what we're doing. So hopefully we can continue to you know, do more in this space to help as well. So please do get in touch. We love to hear from families about things that we can help with. So please do.
Absolutely. Thanks, everyone.
Thanks, Daryl. Thanks,
Good
Jas.
evening.
Thanks,
See ya.
everyone. Bye-bye.